Okay, well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville, and today I will be serving as your program facilitator. I will help present your questions to our panel of top neurosciences and pain management physicians, focusing on back and neck pain and other spine-related issues, as well as spine treatments, including spinal surgery. Our spine and pain specialists will answer your questions about treating back and neck pain, spine conditions, when spinal surgery may be necessary, and what to expect. They'll also discuss recent medical and technological advances and research breakthroughs. Our spine teams work together with our patients to treat, prevent, and find cures for all kinds of spine disorders using an array of surgical procedures, including minimally invasive surgery and robotic spine surgery. And tonight we are joined by our four panelists. So please join me in welcoming Dr. Jonas Gopez with spine surgery and neurosurgery, Dr. Christian Holscher with spine surgery and neurosurgery, Dr. Ahilan Siviganasan, also goes by Dr. Siva, with spine surgery and neurosurgery, and finally, Dr. Christopher Fico, rehabilitation and pain management. Well, thank you so much for submitting your questions in advance. And if you have any questions throughout the discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. If you don't see it, maybe just try moving your mouse around a bit and it should appear. But please go ahead and select that Q&A icon and you can enter your question right there in the text box. For those joining us by telephone, if able, please email any questions to marketingevents@jefferson.edu. And we'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases or the number of patients we have treated or are currently treating. Likewise, if you are experiencing any symptoms that may require medical attention, please consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate any background noise, so feel free to move around and get comfortable. So with that, I want to give each of our physicians a minute to say hello, and then we'll move into your submitted questions this evening. So Dr. Gopez, we'll go ahead and start with you. How are you doing this evening? Oh, I think you might be on mute. There you go.
My apologies. Thank you, Sarah. I'm doing great. I'm glad to be here tonight with some of my other Jefferson Health colleagues. I want to thank the audience for allowing us to spend part of your evening with us. I think you're going to find tonight's dialogue to be very educational. And with that, we hope that you gain some insight into some of the spinal issues that you or maybe your loved one may be having. Just a quick verb on myself. I'm a neurosurgeon. I've been here at Abington since 2003. The vast majority of what I do is treatment of the spine. So if you're out in the Abington area, please feel free to look me up.
Okay, well, thank you so much, Dr. Gopez, for that welcome. All right, let's turn it to Dr. Holscher. How are you doing this evening?
I'm doing great, Sarah. Thank you for having me. So, yeah, like Dr. Gopez said, I'm also looking forward to the dialogue and the conversation tonight. Always great to have an opportunity to reach out with patients in this kind of a forum where we can, speak to so many more people than we can speak to at one time in clinic. Like Dr. Gopez, I'm also in the suburban Philadelphia area. I'm actually practicing in South Jersey. So my practice is based in Washington Township. I did my training downtown and Center City at Jefferson and did my spine fellowship there as well. And I also deal primarily with issues relating to the spine. Excited to be here.
Great. Well, thank you. I know we have a lot of questions to get to, so we are excited. Let's go ahead to Dr. Siva. How are you doing this evening?
Hey, it's Dr. Siva. Thanks so much for involving all of us, and it's a great opportunity to talk with everyone. Briefly about me, I did neurosurgery residency at Vanderbilt and then did a fellowship in minimally invasive spine surgery at the Hospital for Special Surgery in New York City. And now I'm here at Jefferson. I see patients at the Navy Yard and in Delaware County, primarily, and I do surgery at the Methodist Hospital in South Philadelphia, as well as downtown at the Thomas Jefferson University Hospital. So looking forward to talking with everyone.
Great. And finally, Dr. Fico, let's turn to you. How are you doing this evening?
Thanks, Sarah. And yeah, I want to echo all the sentiments so far. I'm pleased to be here and looking forward to what I'm sure will be a lot of lively discussion about pain-related issues. About me, I also am a Philadelphia native. I trained at Jefferson in rehabilitation medicine. I've been at Jefferson since 2011 as a resident, and then 2014 as an attending. My background is in rehab, as I said, and in the last year I did maybe the unthinkable and decided to go back and do a fellowship in anesthesiology in pain medicine, and I now have a combined rehabilitation and pain medicine practice. I see patients out of Center City and also out of Methodist, and we do interventional procedures for pain management out of Methodist.
Okay, well, thank you so much all for the great introduction. And I think we're ready to dive right into it. I know we've received a ton of engaging questions, so we're going to be learning a lot tonight. But let's jump into it. Question number one, Dr. Fico, I'll start with you. Okay, a question from the audience. How do I know if my back pain is serious enough to see a neurosurgeon?
I think that's a great question. And I'd say, there's not really one prescribed answer. I think that what I would tell my patients is, if you're asking yourself that question, there's probably, some level of concern or doubt in your mind. But the way that I would typically encourage patients to look at their pain is, if your pain is one that is disrupting your life, disrupting your ability to work, your ability to enjoy your family, perform your duties in your family or at your work, I think then that if it impairs your sleep, I would say to you that it might be something to consider evaluation for. In terms of things that I would say are more of a red flag, and that's perhaps the second way to look at it is if you are experiencing pain that is changing or worsening, pain that is associated with worsening function, perhaps weakness, or even things like changes in bowel or bladder function, that would absolutely need to be evaluated, most likely in a more urgent setting.
Okay, thank you so much for that helpful information. All right, Dr. Gopez, let's turn to you for our second question. What are the differences between sciatica and SI joint inflammation pertaining to diagnoses and treatments?
Well, that's another great question. And these are two very different entities. Let's start with sciatica. So sciatica is the term that describes the pain that radiates from the low back and down the legs. It could be one, it could be both legs. And the source of that pain is from a pinched nerve in the lumbar spine. The nerves that are in your lumbar spine, they travel down your legs, and that's why you experience the pain in the legs. But each one of these nerves sort of follows a very specific pattern. The good news is that the vast majority of back and leg symptoms resolve within a couple of months. But if it doesn't, then it deserves further workup and diagnosis. And an MRI is usually the best way to do that. The usual culprits are going to be either a herniated lumbar disc or lumbar stenosis, both of which will irritate those nerves and cause the symptom to show up in the leg. In terms of treatment, your doctor or your treating doctor will generally start you on some type of anti-inflammatory medication. Usually physical therapy is initiated. If those treatments fail, the next step would be a consultation with a pain management physician for lumbar epidural steroid injections. But if those treatments fail and your pain is significantly affecting your ability to work or perhaps your lifestyle, then you have to consider surgical intervention. And the most common operations would be a microdiscectomy if it's a herniated disc, or a laminectomy if it's spinal stenosis. Now, SI joint inflammation is a very different problem. With sciatica, the problem is a nerve, but in SI joint dysfunction, it's a bad joint. And this joint sits between your tailbone or sacrum and your iliac bone, which forms your pelvis, and you have two. So you have one on the left and one on the right. The symptoms are generally pain in the back, buttock, hip, groin, and maybe a little bit in the thigh, but you really should not have any symptoms that go below the knee. In terms of diagnosing it, imaging is rarely helpful to make the diagnosis. And in fact, the imaging of the sacroiliac joint will typically be normal, but your treating doctor should evaluate your lumbar spine and your hip with either x-rays or MRI studies to make sure that the lumbar spine or the hip is not the source of those symptoms. The best way to actually diagnose it is by injecting the joint with an anesthetic. And if that temporarily makes your pain go away, knowing that it's only going to be short-lived, that's the best way to clinch the diagnosis. It just so happens, though, that patients that have undergone a lumbar fusion are at highest risk for developing SI joint dysfunction. In terms of treating it, therapy, anti-inflammatory medications, injections can be done. If those symptoms, or if the symptoms persist despite those treatments, one could consider a fusion of the actual SI joint.
Okay. Well, thank you. That was some incredibly helpful information. Appreciate you detailing through that for us. All right, let's continue with the questions that we have for this evening. Dr. Holscher, we'll go to you this time. What are symptoms of stenosis in neck and spine?
Yeah, so very common question that we get in clinic, and even just the way the question is worded, it kind of goes over some of the confusion that we see in clinic. So neck and spine, like sometimes people don't understand what we mean by spine, and that really runs the span of your entire vertebral column. So from the cervical spine, which is the spine in your neck, to the thoracic spine, which is the portion of your spine between your ribs, and the lumbar spine, which is your low back. And stenosis referring to narrowing around the nerves, typically related to degenerative disease or arthritis. So I like to think of symptoms from degenerative disease in the spine into two different categories. And one is what we would call midline or axial symptoms, and the other are the symptoms you get in your limbs, in your arms and your legs. And so the midline symptoms, like neck pain, or really, that's what it is. It's pain either in your neck, in your mid-spine, or in your low back. And that's really difficult to treat because it's kind of this nebulous thing. Like narrowing and compression of nerves typically causes some combination of symptoms in your arms and legs, but pain in your neck or in your mid-back or low back can be related to pressure around the nerves, but can also be just to related to diffuse or intrinsic arthritis, for example, in the discs or the joints of the spine. Can be also related to musculoskeletal injuries, to weakness of the core paraspinal support muscles, or a variety of other reasons. And so midline or axial pain is difficult to treat surgically, and typically the focus of surgery for the spine is on stenosis that causes compression of nerves. So the symptoms we get in our arms and legs will depend on which nerves are compressed. And in which portion of the spine those nerves are compressed. And I give patients in clinic often the analogy of a tree, like the nerves in your body are like a tree. And the spinal cord is the tree trunk. And if there's dysfunction in the spinal cord, we call that myelopathy. Everything downstream of that, the whole tree, so to speak, can be affected. So spinal cord compression or myelopathy, most commonly in the neck, will usually manifest less commonly with pain, but more commonly with kind of diffuse numbness in both arms, in both hands, tingling, and some amount of clumsiness. So often any tasks that require fine motor. So for example, clasping jewelry, buttoning buttons, writing with a pen or pencil. Very easy in clinic to just put a dime on the table and ask a patient to pick it up with their thumb and index finger. And oftentimes they struggle with that. And it's usually not one side or another. It's usually both sides. And you may also have numbness and tingling in the torso or in the legs. And classically also difficulty walking, so gait instability. And that's pretty typical of cervical spinal cord compression. When you have thoracic spinal cord compression, so compression of your spinal cord, between your ribs, that's less common certainly than in the neck, but you'll get pretty similar symptoms, just sparing the arms. So numbness and tingling really in the torso and the legs, heaviness in the legs, again, difficulty walking because of intrinsic gait instability, kind of feeling wobbly, or people will say, I feel drunk when I walk. And that's myelopathy, and that's distinct from compression of individual nerve roots. So when you think about nerve roots, you're thinking of a branch, for example, that's coming off the tree trunk. So now what's going to be impacted is not every leaf on the tree, but only the twigs and the leaves that come off of that branch, right? So for example, if you have a herniated disc at C5-6, you may have compression of the C6 nerve root on one side or another. That's more typically going to be one-sided. It's more typically going to involve numbness, tingling, or weakness just in the distribution of that nerve root. So for example, a C6 radiculopathy or nerve root compression will cause numbness, tingling, pain, maybe down into the, across the shoulder, into the bicep, into the thumb and index finger, maybe some weakness in the biceps. And again, oftentimes on one side, and you'll typically be spared kind of the diffuse bilateral numbness, the intrinsic gait instability. In the low back, you're going to have similar kind of symptoms, but impacting the distribution of a nerve in your leg. So for example, patients will always complain of sciatica and use that term kind of generously, but it essentially means pain that radiates in the distribution of that compressed nerve root. And those nerve symptoms in the legs and arms are typically a little bit easier, I shouldn't say easier, but a little bit more definable and more amenable to surgery typically.
Okay, well, thank you. And I think the audience will really appreciate that tree analogy because that paints a helpful picture. So appreciate you taking us through that. All right, well, let's turn to Dr. Siva. Can you talk about minimally invasive spine surgery and what does that mean? And what does it mean my recovery time may be like? Would that look a little bit shorter perhaps?
Yeah, it's a great question. I think the phrase minimally invasive surgery gets thrown around a lot in every field of medicine, and sometimes it can be hard to know exactly what that means. In my mind, minimally invasive spine surgery is really about accomplishing the same goals as traditional spine surgery, but doing it in a way that minimizes collateral damage to the surrounding soft tissue. And so the analogy that I use sometimes is that if you needed to remove an old couch from your living room, traditional surgery oftentimes can feel like you have to blow the roof off the house, come in with a helicopter and airlift the couch out. You need to see all the anatomy directly, you need to move muscle and soft tissue out of the way. With minimally invasive surgery, what we try to do is to go in through natural openings in the spine, and instead of cutting and dividing muscle and soft tissue, we just go naturally displace those muscle fibers to get to just to where we need to go. So it's akin to sort of taking a key, opening the front door, and then pulling the couch out of the house. And so what that means more practically, for example, is if you have a pinched nerve, using a small tube to actually dilate the muscle fibers and get down just to the area where the nerve is getting pinched, doing the work to free up the area around that nerve, and then pulling the tube out and having, oftentimes a much smaller incision that might be required with traditional surgery. There is something else even more new that's come about in the last few years, endoscopic surgery, which we do offer here at Jefferson. And that's what's now being called ultra minimally invasive, where you make almost a Band-Aid size stab incision in the skin and then pass a camera that's the width of a pencil down to the area of the spine and use the natural openings into the spine to get to the area where a nerve is pinched, free up that area, decompress that nerve, and then remove the camera. And then those patients can go home an hour or two after surgery. I think the key principle is that not every patient is a candidate for minimally invasive spine surgery, but most of them can be. Some people might be afraid that, well, is this sort of like a shortcut surgery where, you know, maybe the incision is smaller, but are they going to do as good of a job as traditional surgery? In many cases, you know, you can get the same quality of decompression, and if your spine needs to be stabilized with screws and rods, that can also be done minimally invasively. And so I think it is something worth asking for any patient that is considering surgery, just to ask your doctor if that's something that there may be a role for. In terms of what that means on the back end after surgery, when the surgery is done specifically to relieve pressure on a pinched nerve, honestly, I think that the differences between traditional surgery and minimally invasive surgery are kind of marginal, because oftentimes, even with traditional surgery, you can leave the same day or the next morning, and that's the case with minimally invasive surgery as well. Where I think the differences are more profound is when you have to have a fusion, for example, where oftentimes you may normally expect to stay in the hospital for 2 or 3 days, but with minimally invasive options, oftentimes you can leave the next morning or even sometimes the same day. There is good data that shows that infection rates are lower with minimally invasive surgery because the incisions are smaller and there's less muscle and soft tissue damage. Length of stay can be lower as well. Narcotic use after surgery, opioid use can also be less because of the reduced tissue trauma. I think there's a real role for it, and it's at least worth asking the question if you're seriously contemplating spine surgery.
Okay, well, thank you so much. A good question to ask, and just exciting to hear about all of this latest technology. Okay, Dr. Fico, we'll go back to you. A question from the audience. What can you suggest for SI joint pain? Oh, and you might be muted.
I'm muted.
Oh,
Yep,
there you
sorry
go.
about that. I'll start there. Yeah, this is a great question, and I think Dr. Gopez touched on a lot of the issues. I would say in the rehabilitation and in pain world, or from our perspective, I think SI joint pain can be a bit of a more difficult pain generator to be absolutely sure of, and I think it takes a lot of work to arrive at that diagnosis. So I would say first and foremost, the most important thing when you're looking at that is to make sure that you're treating the right thing and that the pain is indeed coming from the SI joint. And I say that because you can get pain referrals from other structures in that area, namely the hip, the deep gluteal muscles, and the myofascial pain that can be generated from those structures. And also, as Dr. Gopez mentioned, the low back, and some of the joints in the low back can refer pain to that area. So there's a lot of overlap, if you will, in terms of what can hurt in that area, and then the process to make sure that you confirm that diagnosis. But if we did think that someone had SI joint pain, I think there is a lot of options even before you get to surgery. So from a rehab perspective, I think first and foremost is really looking at is there a structural asymmetry that could be leading to increased load bearing on the SI joint. I think that there can be conditions where there may be some increases in the amount of movement at the SI joint. Now, there's not a ton of movement, when you compare the SI joint to the knee, but there is some amount of rotation that occurs at that joint. But a good example of that would be during pregnancy. There's changes in the pelvis, and that laxity can sometimes lead to straining of some of the ligaments around that joint, which are again another potential generator. So when we're looking at those sorts of causes, I think the way to approach it is to try to strengthen those muscles that cross the SI joint, so around the pelvis, to try to support them. And one of the ways we can do that is with some bracing. There are some nice compression belts that may give some patients relief. If there's increased mobility, or in the setting of a condition where we think that there may be increased mobility, there are procedures that can be done to try to minimize that hypermobility. And there's some data to suggest that those could be helpful. And then I think that what we are typically doing, if those didn't work, we would try to take an approach where we could try to treat that pain. Now, this joint is not very deep from the surface of the skin, which is nice. And sometimes we can get a good response with topical agents. So there's things like topical lidocaine, which may numb the area and numb the activity coming from those nerves, those pain signals that those nerves are sending. If there's inflammation, anti-inflammatories, things like diclofenac or Voltaren could be helpful. And then if those approaches didn't work, where we would typically then look at going is performing injections into the joint. And those could, as Dr. Gopez mentioned, could be either a diagnostic injection, which is usually just with local anesthetic. And then if there is good response to that, then we would hope for longer lasting relief by giving a combination of medications, but including a corticosteroid. And then the last thing I do want to mention, which I think is growing in popularity, is the approach to try to help with changing the electrical activity that those nerves that innervate that joint are sending back to the central nervous system and that are going to our brain and our really experience this pain. And so one of the approaches that is out there is to actually apply an electrical current to ablate those nerves. And in doing so, the hope is that you can then block that pain signal that's being generated from the degeneration in the joint. And the reason that's important is because while there may be an acute process happening at the joint or even a chronic degenerative process, any of the approaches that we take and potentially even if we were to stabilize the joint, it doesn't necessarily mean that we always have a change in the activity of those nerves in that area. And there is the potential for persistent pain. And when we run into issues like that, looking at procedures like radiofrequency ablation have a growing role in terms of helping those patients with complex SI joint pain.
Okay, well, thank you. And just again, really interesting to have you take us through that. So thank you again. Dr. Gopez, we will now turn to you for another question from the audience. What are the best preventative measures to minimize neck pain and discomfort?
Another great question, Sarah, and there are quite a few things that one can do to prevent or minimize neck pain and discomfort. First and foremost, there's not a day that goes by when I don't see someone sort of crouched down with their head flexed, looking at their smartphone. They might be sitting, they might actually be standing, or they could even be walking, but they have this hyperflexed posture where they're looking at their smart device. And over time, the cumulative effects of that are not very good for the neck. So I know it's a bad habit to break. I'm guilty just like the next person, but perhaps holding the phone higher or your smartphone higher so that you're not forced into that downward flexed position of the neck over the long term will prevent or minimize any future neck issues. Another thing is for those of us that spend most of our working day on the phone, the constant position of pushing the handset with our arm elevated, pushing the handset against our ear and tilting our neck perhaps to try to keep the phone in position is also very bad for the neck. So it's also bad for your arm, bad for your ear. And I would recommend that you either use a headset or some kind of hands-free device. But I think now with the advent of Zoom, I think a lot of those issues are also going to go away. For those that spend a lot of their time looking at computers, it's essentially unavoidable. The height at which you keep your monitor is critical. So whether you're sitting or standing at your workstation, if you're looking straight ahead at your monitor, your eyes should fall onto the upper half of that monitor. It should not be low, so you should not be looking at or looking down rather at the screen. And by the same token, you should also not be looking up. So getting that monitor just at the right level will improve things. Another thing that we could do is avoid heavy shoulder bags, especially laptop computers. That asymmetry will put asymmetric pressure onto the neck and could lead to future problems downstream. Unfortunately, I think it is a bit unavoidable that we do got to carry and lug around quite heavy things, and perhaps the best way to do that would be with a backpack where the weight is evenly distributed. In terms of sleep, sleeping on your back is actually the best thing for your neck, but a good percentage of folks are side sleepers. And so I think it's important that if you are going to be a side sleeper, that you build the pillow high enough to keep your cervical spine in a neutral position. Doing stretching and strengthening exercises are also critical. Several of these are available online to show you how to perform them correctly. Most of them involve tucking your chin back and doing that several times a day will, over the long term, reduce any future neck issues. The last thing is to stay well hydrated. The bones of the neck are separated by discs, and a healthy disc is one that is well hydrated. So drink lots of water.
Okay, thank you. That was a lot of helpful information there. And I'm certainly happy. I recently bought a laptop stand to raise my laptop, so I have noticed a difference, and I'm glad you included that. Dr. Fico, is there anything you would like to add to that list, but pretty comprehensive there?
Yeah, I think Dr. Gopez really hit the nail on the head. I really don't. I would say, though, that I agree with some of the underlying environmental and causes that we're all experiencing socially, which is really, I think, the growth of work from home. And all I would add to what Dr. Gopez had to say is that you want to be mindful of the ergonomics of your workspace, and just like you would do the same thing in your workspace in your office, which again, I think a lot of people maybe inherit their office and don't really have much of a say in where they're working, but let it be known that most of the time, at least in a sedentary desk-based job, you're typically working at a workspace where your hips are at 90 degrees, your knees are at 90, bent to 90 degrees, your feet are flat on the ground. And I think that work from home, a lot of people, I think, have had to learn the hard way that their work environment is not ideal. And I do agree with everything that Dr. Gopez said, but I think that if you are working from home, treat your body right and well, and take the time to look at your workspace. There's lots of good tutorials online where you could do some very quick assessments and make some, fairly simple adjustments just in terms of raising up your desk space, making sure your computer is on a stand if it's too low. And then in doing that, I think your body's going to thank you, and you'll hopefully avoid any overuse or disuse sort of injuries.
Okay, perfect. Thank you. I know a relevant conversation for sure with all the working from home. So thank you. Okay, let's turn to talk a little bit more about the latest techniques and technologies. Dr. Siva, we'll go to you. Can you talk about any of these latest technologies in neurosurgery happening now?
Yeah, it's a great question. I think I'll speak to two or three. There's a lot out there, but three that may be most salient for individuals, with questions about the spine. One I already mentioned a little bit earlier, which is endoscopy, which is sort of the fancy word for procedures where you go in with a small camera and tube to get access to the spine to free up area around nerves while minimizing the damage to the surrounding tissue. One reason why endoscopy might be relevant for patients is that traditionally there are situations where the nerves are so impacted and pinched that you would normally have to remove a lot of normal bone in order to get at the area where the nerve is getting pinched to be able to free it up. And in doing so, there's a risk of destabilizing the spine because that normal bone there is serving a purpose as structural support. And so then if you have to do that to adequately free up a nerve, then you have to put in sometimes screws and rods to hold things in place. We're seeing now that with endoscopy, it's such a narrow working tube that we use, that you can often free up the nerve without having to do so much of that bony work and bony removal. And in many cases, you can avoid a fusion. We saw one patient in clinic just a few weeks ago who for which normally the option would be to do a fusion in order to be able to adequately free up a given nerve that was getting pinched. But we were able to go in with the endoscope and free up that nerve. And instead of having screws and rods and being in the hospital for say 2 or 3 days, she was able to go home the same day with her leg pain gone. Now that's not a guarantee for every patient, but there are select patients where you can potentially avoid a fusion by using an endoscope. And so I think that's one new technology that we have here at Jefferson that can be relevant for some patients. The second one that I'll mention is robot-assisted spine surgery, which we also have at Jefferson. I think there's one at Abington, I believe, that Dr. Gopez's team works with. We have one down at the Methodist Hospital as well, and there may be other sites also within the Jefferson enterprise. The robot-assisted spine surgery can be helpful in a couple ways. If you do need screws and rods placed specifically in the low back as part of a spinal fusion operation, the traditional way of doing that is what we call freehand, where the surgeon relies on a combination of intuition and direct visualization of the anatomy in order to place the screws. And there's a lot of data coming out now that on average, when you have either robot-assisted spine surgery or what we call image guidance, where we use a sort of GPS system to assist in this process, that the accuracy and the speed of the procedure improves. And so in certain select cases, a robot-assisted spine fusion can really help sort of deliver the sort of perfect, accurate result that a surgeon would want to see in a patient in their surgery, what they sort of have in their mind's eye before they start the surgery, and sort of maximize the chance that the end result and the end x-rays look exactly the way they would have wanted it to every single time. So that's a benefit of robot-assisted surgery that we have at Jefferson that I think it's worth at least asking a question about when you see a doctor. And then the third technology that I think is worth mentioning is around motion preservation. And so, everybody's sort of heard the mantra that, hey, don't get a back fusion unless you really, really need one. Don't get a neck fusion unless you really, really need one. I think there's some truth to that. And so it's worth asking your doctor if you're considering, for example, a surgery that involves putting a plate and screws in your neck or screws and rods in your back, as if there is a motion preserving alternative that is worth talking about. And in the neck, it's basically what we call a cervical arthroplasty or a cervical disc replacement. In the same way that, 40, 50 years ago, if you had a hip problem or a knee problem, you would end up getting those joints fused. That's what we do in the spine a lot of the time. But in certain select patients, instead of getting a neck fusion, you might be a candidate for a cervical disc replacement, which preserves the range of motion in the neck, and we're finding now reduces the chance of needing subsequent surgery in future years. You got to be the right candidate for it. So if you have too much arthritis in your neck, or if your disc is severely degenerated, or if you have a problem with an alignment in your spine, you may not be a good candidate, but it's at least worth exploring. And even in the low back, Jefferson is now part of a national randomized trial where we are offering certain patients the opportunity to undergo surgery in the low back, where as an alternative to a fusion, you undergo a surgery which replaces the diseased joints and discs. And so it remains to be seen whether these kind of procedures, specifically in the low back, are equivalent to the traditional lumbar fusion. But just goes to show that there's a lot of new technology coming to the forefront, and it's worth at least talking to your doctor about it. So I think endoscopy, using a small camera and tube to access the spine to avoid a fusion, robot-assisted spine surgery when you do need a fusion, and then arthroplasty, cervical disc replacements and lumbar joint and disc replacements, I think are some of the interesting things that are coming down the pipeline.
Hey, well, thank you. Super interesting. Very exciting to just hear all this innovation happening. So thanks so much for sharing those latest updates. Dr. Fico, we have a question for you from one of our audience members. they said that they recently heard of good results for lower and upper back pain using stem cell infusion. So just wondering if you could talk a little bit more about that.
Sure. Yeah, I think that stem cells and stem cell based therapies are, probably one of the, have a very potentially promising future. But I also think that there's a ton of debate, and also, to be quite frank about it, maybe even some misuse at this point. In terms of where that technology is at. So to put it in general, there are ways that you could get out there and be able to find practitioners who practice regenerative medicine, and I would say that using stem cells falls under that. And the theoretical basis here would be that you want to take a stem cell, which is a what we would call a progenitor cell, and a cell that there's these terms that describe what they're capable of doing. And the idea would be, if you can find a cell that is potent in terms of what it can become, so we call those pluripotent cells, the theory there is, why not put some stem cells into an area where there are degenerative changes, especially in those tissues in the neck, in the back, specifically in the setting of degenerative disc disease. Theoretically, that could helpfully potentially halt, or maybe even has the potential to reverse those changes. Now, I would say that from my perspective, in terms of what clinical data is out there, I would say that I think that first and foremost, it has to demonstrate safety. And I think following that very, very closely is that we want to see that there's clinical efficacy. And based on what is available now, I would say that there isn't strong data to support that use. I think one of the biggest issues that is in delivery. And when you think about how do you access the intervertebral disc, a lot of the technologies that were out there from a pain perspective would compromise the anatomy of that disc and potentially lead to complications down the road. So there have been different therapies that have been available in the past that have been in vogue, and then on longitudinal study of those outcomes have found that maybe the intended factor that was to be treated improved. There were other untoward outcomes or complications that weren't intended from that. So I think, to answer the question, I think that regenerative medicine has a bright future. I think that stem cells have the potential to really improve many degenerative conditions, because right now we don't have a cure for many of our degenerative conditions. And what we're looking to do is to try to halt things, or to prevent further complication. And I would just caution anyone to, if you were to pursue that, because I know that there are options out there, I think that looking at this from an insurance coverage perspective, I think you're going to be challenged to find approval for those sorts of things. But there are options where, if those were to be pursued, they could be pursued, through, I think, out of pocket costs. So I think as I'll just summarize and just say that bright future, lots of potential, lots of research going on about it. I think we still want to sit tight and really see large scale studies that show safety and efficacy, and not only in the short term, but in the long term without complication.
Okay, thank you. An exciting future indeed. All right, you are not done yet. We have another question for you, Dr. Fico. Going on more of the pain management side of things. So can you discuss current pain management treatments for patients with residual chronic pain following multiple cervical spine surgeries?
Sure. So I think, I think this is something that we do encounter. And I, when this happens, I think everyone is frustrated by it. The patient, their family, I think, the surgical team is frustrated by it. I think that it does present a challenge. And I think that just speaks to the how complex pain is, because it's not as simple as something is damaged and there's pain. Pain becomes chronic based on time, but what we often do see is that even after things heal, there is the potential that pain can persist. And I think that's when you really want to get involved with a pain management physician to try to manage that pain, but also prevent it from causing negative impact on function. So if we do see this, the first thing that I do, my approach is to really talk with the surgeon and to just understand exactly what happened, get a sense of what the time, what the recovery course looked like, and to make sure, and I think this is very, very critical, is to make sure that there are not any other surgical issues going on that could potentially be playing a role, and the patient just hasn't had a chance to get in contact with their surgeon, and now they're seeing a pain doctor. So I think that is probably the most important thing to look at. And then if in partnering with the surgical team, and we said, everything looks good from an imaging perspective, and there's nothing else that would require additional surgery, then we have to look at other options. And I think the area where we've seen the most growth, probably in the last 10 years, is in the field of what we would call neuromodulation. And what we're looking at there is we're looking at trying to alter some portion of the pain pathway. So that can be peripherally in the peripheral nervous system. It can be at the in the spinal cord level, or it could be at the level of the brain. And there's a lot of very, very cool technology that's out there. And it seems like almost every year there are new hardware and software options available that seem to really improve on what we can do when someone's experiencing chronic pain. So in terms of just options that are there, if we thought that someone had pain, as Dr. Holschler had mentioned about the analogy of the tree, which I really liked, say for instance, someone had pain in the distribution of just one of the small little branches, that might be akin to, he was talking about a nerve root, but that might be akin to a peripheral nerve. And when there's pain like that, say for instance, in the arm or in the foot, we could try something like a peripheral nerve stimulator to apply electrical current to try to modulate the signaling of those nerves. And then looking at other pain that may be coming from some of our nerve roots, or even at the level of the spinal cord, where we know that there are, just like there are positive plastic changes that we often talk about in recovering from certain diseases like brain injury and stroke, there can be negative plastic changes that occur in the periphery and in the central nervous system. And so using something, an implantable technology like a spinal cord stimulator, or even more specifically, something like a dorsal root ganglia stimulator, are devices that, again, are placed through a very, very, they're actually placed through a needle and are then connected to what's called a generator or a battery, and are done on the same day, with the patient allowed to resume activities as normal. And what we've really been able to see, again, in the last few years, is a tremendous amount of growth in those areas, and also very good outcomes in terms of treating persistent pain that goes down into the limbs, but also pain as it persists in the back. And then the last area that I think I just want to mention to you all that are options for chronic pain are implantable pumps that deliver medication into the spinal cord, specifically around the spinal cord in what's called the intrathecal space. And these devices are devices that allow you to avoid a lot of the bad side effects that we see when people take medications by mouth. The issue there is that while those medications may help, the dosing of those is often limited due to side effects, because those medications circulate systemically. And so to be able to deliver the medication at doses that are 100 to 300 times smaller, that avoid a lot of the systemic uptake, really does potentially reduce the potential for side effects, and then also really does allow us to target therapy, because you can use multiple different medications through that pump, and because of that, we've really been able to really improve patients with chronic pain while minimizing side effects.
Okay, great. Thank you. It's just great to hear the number of treatment options available. So thank you for taking us through that. Now I think we'll turn a little bit to the research side of things. So Dr. Holscher, could you give us an update on spine, neck, and back pain research happening around Jefferson Health?
Yeah, I mean, that's a huge topic, and something that's is really difficult to address in any scope or complexity in this environment. I think just some of the responses that we heard from some of the panelists just to the last couple questions, right, about stem cells and minimally invasive surgery and motion sparing technology, like all that speaks to innovation and research that is ongoing in many institutions across the world, and certainly Jefferson is no different. One thing I would say is Jefferson has done a really wonderful job of fostering an environment of creativity, of discovery, of innovation in all aspects of medicine. Like, it's not just neuroscience, it's not just spine, really in all facets of medicine. As it relates to what we do in neuroscience, you can definitely tell that Jefferson has really put their weight behind neuroscience and has really put their money where their mouth is, so to speak, with the creation of the Vicky and Jack Farber Institute for Neuroscience. And so that's a centralized organization to all of neuroscience at Jefferson, not just neurosurgery, but neurology, neurosurgery, psychiatry, et cetera, like all aspects of care as it relates to brain and spine. And that translates not only into clinical practice and to, taking care of patients, but also to research. So for example, when I was a resident, towards the end of my residency, I remember in 2018, we actually had a little party in the resident room because the Jefferson neurosurgery residents were recognized amongst all neurosurgery programs in the country. So all 117 neurosurgery programs, we were ranked #1 for resident output of academics. So peer-reviewed journal articles, textbook chapters, conference presentations, et cetera. And so that speaks to like that environment of thirst for knowledge and discovery. And that environment doesn't exist in a vacuum, right? That starts from the top and comes down. So the ability of our residents to be able to perform that research starts with having not only the resources to do it, but then faculty members as mentors who are performing various research studies that the residents can be a part of, right? And so, research at Jefferson as it relates to the spine is multifaceted. It spans, bench research, basic science in the laboratory to all sorts of clinical projects. So we've already heard, for example, about sacroiliac joint dysfunction and sacroiliac joint fusion. I know one of my colleagues has recently run a clinical trial on image-guided minimally invasive SI joint fusion for patients with refractory SI joint pain. Minimally invasive posterior cervical spine fusion, so fusion of the spine from the back in a minimally invasive way as an adjunct to people who are getting fusions to their neck from the front and are high risk for having a failure of that fusion. That's another clinical trial I can remember that was recently being completed in Center City. Neuromodulation, like we just heard about from Dr. Fico. So there's been tremendous innovation just in the last 10 to 20 years, for example, in spinal cord stimulation, the ability to target pains that were typically not well targeted, for example, like back pain or neck pain, axial pain, like we talked about earlier, which historically was not well targeted with spinal cord stimulation, but due to better understanding of the technology and new and proprietary stimulation protocols from various device companies is now being better applied to treat pains that were not easily treated before. And Jefferson is a huge, it has huge activity in all aspects of neuromodulation, and certainly spinal cord stimulators is a big part of that. All sorts of clinical trials as it relates to how we care for patients in the hospital. One of my partners downtown, actually the director of spine in Center City, has really done a very interesting study trying to catalog all of the elective lumbar fusions that have been happening on our patients, because believe it or not, even though people have been getting lumbar spine fusions for decades, for 50 plus years, probably, much longer than that, the understanding of who really benefits from fusion versus who maybe doesn't need a fusion is not always crystal clear, and it leads to tremendous variability from one institution to another, even within one institution from one provider to another, about whether or not somebody would apply screws and rods, to an MRI finding, versus not. And trying to eliminate some of that variability has been a big focus across neurosurgery, but especially in spine, where you can argue that sometimes the decision on how we treat things is art just as much as it is science. And we're trying to kind of skew that more towards science. Spinal cord injury obviously is a huge field and has always been a huge field. I'm sure Dr. Fico can speak to that as well, having, from the rehab side of things, sees a lot of spinal cord injured patients. And there hasn't been a lot of progress, from the, initiation of treating those patients to dealing with, the recovery and trying to maximize the outcome that those patients can achieve. And so a variety of basic science, animal studies, all the way up through clinical trials of how we operate and how we take care of these patients. I can remember as a resident, every time the spinal cord injury alert pager went off, and we have a pager for spinal cord injuries. And unfortunately, at Jefferson being a major academic center, we get a lot of spinal cord injured patients down there. But as soon as we settled on how to take care of someone, how to acutely deal with the injury to the spine, like the reflex was always, all right, call research, because we have a cell phone for our research team. A team that's on call will come 24/7, will come at 2 o'clock in the morning, evaluate a patient, and try to decide what clinical trials they may be eligible for. So, I think it just speaks to, again, that culture of creativity, innovation, desire for knowledge, and not only being on the forefront of how we're practicing medicine today, but trying to be a leader on how we're going to practice medicine tomorrow, next week, next year, in a field like neurosurgery that is, has plenty of unknowns.
Okay, thank you. Needless to say, a lot happening for Jefferson research. So thanks for going through that, and really exciting to just hear about all of that innovation. Okay, so just before we dive into all of our live audience questions that we're getting throughout the evening tonight, we will just have a few more questions. So Dr. Gopez, one for you from the audience that we received earlier. Is stenosis a recurrent situation after back surgery?
Sarah, the answer is yes. And if you take a patient that has had a lumbar laminectomy and has had an instrumented fusion, the incidence for recurrence is actually fairly high. But the area of restenosis is not necessarily at the operative level, so not at the levels that were decompressed and fused, but it'll be at the junction point, so where the fusion ends and meets the rest of the spine that is not fused. And it's because those junction points start to become more mobile, and as they become more mobile, they're going to degenerate quicker, and as a result of that degeneration, you're going to get the stenosis at the junction points. So roughly a third of patients that have had a lumbar laminectomy and a fusion will go on to need additional surgery at those adjacent levels within the next 5 to 7 years. Unfortunately, the fix for that is to extend that fusion. And by doing so, you're sort of chasing yourself. So those patients have a good chance of requiring additional surgery past that second surgery in the near future. In the patients that have had the laminectomy without the fusion, those patients can also develop recurrent stenosis, but the incidence is less. And since we're on the topic of recurrence, patients that have herniated lumbar discs that have gone on to have a lumbar disc procedure, those patients can also develop recurrent disc herniations, and the chance for that can be as high as 20%.
Okay, thank you so much. Really incredibly helpful information there as well. Dr. Holscher, we'll turn it back to you for just a minute. So before jumping into our live questions, so do you mind answering what is the plan of action for lingering symptoms post-surgery? So when is it known that nerve damage might be permanent?
Yeah, and so before we get kind of into the answer for that question, I think it's important to take a step back and just really highlight the importance of two things. And one is the preoperative workup. And it can seem frustrating for patients sometimes where you're coming back to clinic again and again, and it seems like we're talking about the same thing and again, and we're getting all these different studies. We're getting X-rays, we're getting CAT scans, we're getting MRIs, we're sending you to physical therapy, we're going to see a pain management doctor, maybe we're considering a variety of different injections, maybe we're getting an EMG and nerve conduction study, and a lot of that happens successively rather than at the same time. One, because it can be very overwhelming for a patient to deal with all that at the same time. And two, oftentimes your insurance kind of mandates that we kind of have a stepwise progression of what we're looking for, what we found, and why we're justifying the cost of treatment X, Y, or Z, or study X, Y, or Z. But it's important because our job as providers is to try to tease out, as has been brought up by a couple of panelists here, what is driving your pain. And it's important to understand that almost always in medicine, things are not black or white. Things are almost always a shade of gray. Like, it's very rare that we see in our clinic that really pristinely healthy 20-year-old person with a pristine spine who has a large L4-5 disc herniation and leg pain that is completely concordant with what we see on the MRI. Right? Oftentimes we're dealing with a patient that is, middle-aged, late middle-aged, elderly, that has a whole host of medical problems, that probably has diabetic neuropathy, that has multiple levels of degeneration in their spine, and that has potentially they've had a hip replacement, a knee replacement, they've got SI joint pain, like they've got a lot of things going on. And again, the importance of understanding that the pain that they feel is probably partially from their spine and probably partially from other things, right? And so if somebody has pain that we think is mostly from their spine, they're a better candidate for surgery. But even in that setting, it's important to understand that there are other reasons for why people have pain, and you should be a little bit wary of the surgeon that signs you up for surgery the day they meet you, right? We don't want to be cavalier about making decisions for surgery, because there is no free lunch in any intervention we do, certainly spine surgery. There are always potential, as Dr. Gopez just said, of adjacent level problems, not to mention the complications of surgery. So that's number one. And number two, it's important to understand and really have a good discussion with your provider. Like, what are the expectations for surgery? What is a reasonable expectation for what I can achieve? And oftentimes, unless we address that directly, those expectations of provider and patient don't always, at least initially, line up. And we're not always the best at conveying to you what I think is reasonable. That 20-year-old pristinely healthy patient that has a big disc that happened acutely when she was lifting a heavy sofa is probably going to do really well with surgery, and the likelihood of long-term recurrent issues is really low. That typical patient that has all these medical problems is a little bit of a different story, right? So surgery is not going to turn back the hands of time. Your spine will not, if we do a fusion from L3 to L5 or a decompression only, whatever it is, right? You're not going to have the spine of a 20-year-old anymore. We're going to mitigate what we think is the worst of your pain driver, and we expect you to achieve some better level of function, but it's not going to be like you're a teenager again, right? And so if we can establish that before surgery, that goes a long way towards patient satisfaction after surgery, when typically, like, symptoms are not totally gone. And in most cases, patients are feeling significantly better and get benefit from surgery. Now, when you have the rare cases where there's really persistent or even worsening symptoms after surgery, that's obviously very, very frustrating, but I think it's less frustrating for patients when they understand going into this that there's always some ambiguity, and it's our job to do our best before surgery to make sure that we're applying surgery appropriately, because a surgery done phenomenally well, let's say you get a fusion, the screws are perfect, the x-ray looks gorgeous, if it's done for the wrong reasons, it's a bad surgery. And so, getting that all out of the way and making sure that that's done appropriately is step 1, 2, 3, 4, 5, 6, and 7. Now, when we have lingering pain after surgery, obviously, as Dr. Fico said, the first thing we're going to do after we've had kind of an appropriate cool down time after surgery, there's always some element of neuritis. Things are inflamed. We just operated. But if you're still dealing with the same symptoms, let's say a couple months later, then it's time to get new imaging. Like, we got to repeat the MRI. We might repeat all of those studies we did. We might get another nerve conduction study. And if there's really no evidence of ongoing nerve compression, if there's no, concern for infection at the surgery site, there wasn't a spinal fluid leak, and we don't have, something else that we have to fix, then we start to consider that you may have a chronic neuropathy, or as patients will often say in clinic, I have nerve damage, right? I have lingering pain. And when we look at the MRI, we don't see how to easily surgically fix that. And then there are alternatives to explore for that. And that's a perfect avenue to start exploring something like spinal cord stimulation, where we're trying to deal with neuropathy and what we would consider inappropriate pain signals coming from injured nerves. Or recruiting the help of consultants that deal with pain, chronic pain from a non-surgical perspective, and getting their inputs. And it can be really, really frustrating. But again, I think it's just important to highlight that sometimes lingering symptoms and lingering pain is not, doesn't necessarily indicate failure of surgery. It just indicates and highlights, like Dr. Fico said, the complexity of pain, and the fact that what we do is not as straightforward as it might seem, and having that kind of teamwork approach to it and understanding going into it before surgery that we may have to deal with some of these issues, I think goes a long way towards keeping patient frustration under control. And when we're when we have that partnership with the patient, it's a lot easier for us to work together and try to find a solution to get you feeling better.
Okay, well, thank you so much. Some really helpful things for our patients and prospective patients to keep in mind. So thanks for going through that. I think now we're just going to hop right into our live questions, because we've been receiving so many great questions. Thank you to all of our audience members for submitting throughout this chat tonight. So let's go ahead and dive into it if you're all ready for it. I have the first question, and I think this is probably directed for Dr. Gopez. So if you're ready for it, we'll send you the first live question. Okay, so what's new in treatment for spondylolisthesis? Apologies if I mispronounced that, with stenosis.
That's a tough one, because traditionally, spondylolisthesis with stenosis, and for the other people in the audience that may not quite understand what that is so the spondylolisthesis refers to a malalignment of the bones, whether it's in the cervical spine or the lumbar spine. And because those bones are not aligned, you will invariably encounter stenosis. And with stenosis, you'll get nerve irritation. But if there's frank instability associated with that, you're also going to experience pain in your back. Typically, the solution for that is, so if there is instability and there's nerve irritation, pain, you don't have much of a choice, but perhaps to do a decompression, free up those nerves, but then at the same time do a fusion to lock those bones down so that they don't slip further. At this point, I'm not sure I know of a better way to do that. I might have to defer to Dr. Holscher or to Dr. Siva if they know if there's anything new, perhaps experimental at Jefferson, that you all might be looking at to perhaps do that in a different manner. But unfortunately, what's available prime time now is a surgical decompression and a fusion. And of course, that invites the future problems of adjacent segment degeneration and perhaps needing additional surgery.
And
yeah, I just to kind of piggyback on top of that, he's right. Like, spondylolisthesis is a difficult problem because it implies some degree of instability. And even when we look at the films and we don't necessarily see, let's say, active movement. So we always check what we call a flexion extension X-ray in these patients. And so we'll get an X-ray with them flexing forward and leaning back. And even if we don't see that unstable level is actively moving with range of motion, it still implies some degenerative instability in the joint. And your options then are to do a decompression, only decompression just to take pressure off the nerve roots, understanding that there's some risk of worsening that laxity. To do a decompression, you have to remove some bone, some ligament, some, shave down the inside of the joints. Like, you're removing some of the structural integrity of the spine in a patient that already has clear evidence of degenerative instability, right? And so the risk then is propagating back pain, propagating degenerative disease at that level, and recurrent stenosis. So, developing worsening stenosis even at the same level. So most patients in that setting, if we're going to operate, we typically recommend a decompression with fusion. I think the only real innovation there is different ways of accomplishing the same goal. So whereas, you know, an open surgery, a T-lift, you might hear that word, it's basically an open lumbar fusion all from the back, where and we do the fusion with the screws and the rods. We also try to get a graft or a cage in the disc space to get another surface to fuse across. Sometimes that graft in the disc space can be done in a less invasive way from the side. It's called a lateral lumbar fusion. Alternatively, is sometimes done not necessarily in a less invasive way, but from the front. And then at least the portion of surgery from the back involves less tissue dissection, less work. But I'd say the only innovation there really is, can you try to achieve that fusion in a less invasive manner? There are some minimally invasive, candidates for truly minimally invasive lumbar fusions. I'm sure Dr. Siva probably has more expertise in that, but that's really if the innovation there is just, can you do it in a smaller space with less tissue injury?
Okay. Well, thank you so much. Appreciate both of you hopping in there. Dr. Siva, we'll turn to you. We have a question from the audience. If we are experiencing numbness, tingling, and burning due to spinal issues, does that automatically mean surgery?
That's a good question. I would say that the short answer is no. I think everyone on the panel would agree that even those of us who do surgery for a living, that spine surgery should be the last resort. Spinal fusion, in particular, for the kind of symptoms that you're describing, should be a last resort. Medical management, things like injections, physical therapy, and also making sure that there aren't issues outside of the spine that can be contributing to those kinds of symptoms. It's imperative to have those things explored before jumping to the assumption that surgery is necessary. The temptation sometimes for doctors is, you hear a certain set of complaints and then you have a certain set of studies, whether it's imaging or otherwise, and you have this natural bias to say, hey, well, that doesn't look right on that scan. That probably matches up with the symptom that you're experiencing. We can make that better with surgery. And that sort of thinking isn't done from a place of ill will or greed or anything necessarily, for the most part, but we're all doctors and providers that want to help and use the tools at our disposal to try and help someone get better and get back to the things they want to do. But like everybody else has said on the panel, surgery really only goes well when both the doctor and the patient and everyone else involved is on the same page about expectations. What's the upside of surgery? What's the downside of surgery? Like what Dr. Holter said, there's no free lunch. And you want to have peace of mind when you're going into a process of undergoing surgery. And one way to have a little more peace of mind is to know that you've exhausted all the non-surgical options first. And so if your symptoms are along the lines of numbness, burning, and pain, those are the kind of things where it's good to try non-surgical options. I would say the kind of situations where we tend to sometimes skip over some of those non-surgical options are if there's significant weakness in muscle groups that correspond to nerves that are getting pinched, or to Dr. Holster's analogy with the tree trunk, if the spinal cord itself is getting irritated or pinched, and a patient is experiencing, for example, balance problems or issues with hand dexterity, things like that, you may have to jump a couple steps. But surgery is oftentimes and most often should not be the first option. It should be the last option. And if you can get better without surgery, that's always the best way to go. But a spine surgeon can help you navigate that, or a non-surgical provider, whether it's someone like Dr. Fico or his colleagues. But I think that's an important principle to take away, is that surgery should be a last resort, fusion should be a last resort, and you should try, in many cases, try other options first.
Okay, thank you. Definitely an important perspective to hear from you. So thanks for sharing that. Okay, Dr. Fico, we have a question for you from the audience. Can a pinched nerve in the neck cause hand and foot numbness, and what treatment options are there before trying surgery?
So yeah, so a pinched nerve in the neck. I think this all goes back to Christian's analogy. I think it's a great one. It can cause pain in the if a pinched nerve. What we call a pinched nerve is really usually due to irritation and or mechanical compression of the nerve root. That's usually going to then cause pain in a very predictable pattern. And we're talking about in the upper limb. We call that a dermatomal pattern, and a lot of times we'll ask patients to almost draw it out or show me where you feel this pain, and we're looking to see if the patient or their pinched nerve has read the book, if you will, and kind of convince us, as we've been talking about, is their presentation concordant with hopefully the imaging that we have available. In terms of if there's a pinched nerve, though, typically, again, it depends on the pathology. Most of the time, a pinched nerve is going to be due to something that's causing the compromise of what we call the neuroforamen, or where that nerve exits into the periphery. So if there was pain going down the leg or into the legs, and we think that there, again, from an isolated issue in the neck, I would be more concerned if there was any other symptoms like myelopathy, where again, we were talking about, is it the branch or is it the actual trunk in all the branches? Because that would indicate that there might be some what we call proximal or compression higher up, which could be much more significant. So to answer the question, how we would treat that, I would just, if there were confusing symptoms like that, I would really just recommend follow up with one of the providers to look at how that could be, worked up better, to make sure that we have a clear understanding of exactly what's going on based on their physical examination, based on their clinical complaints, and then based on imaging. There may be ways to treat that in a non-invasive or conservative fashion, but with a complaint like that, I would just want to make sure that you're getting enough eyes on the problem to make sure that we're not missing something.
Okay, great. Thank you so much. Dr. Holscher, let's turn back to you. We have two questions we're going to lump together for you here. Okay, the first question, what can be done for a person who has both SI, sciatica, and all 5 lumbar discs are bulging? And then a follow-up to that, audience member would like to know, what does SI stand for?
Yeah, so I mean, I think the first question, it's really kind of a perfect follow-up to the discussion we just had about the importance of the preoperative workup. Like that 20-year-old patient with the single isolated big L4-5 disc is really rare. Like most people who come to our clinic, like people will always come to clinic and tell you that they have, so many discs are bad, or they have, every disc is bulging, and that's true. It's difficult, and you have to be careful trying to interpret the radiology report of your MRI, where those are basically professional image interpreters, right? They will nitpick every single little detail. And when you have, if you're a, typical patient who's a little bit older, who's had some wear and tear, some degenerative disease, like your discs are not going to be perfect. Every disc is going to bulge. There'll be some component of, overgrowth of the joints and the ligaments. And deciding, is that really driving your pain or not, is really, really challenging, right? Like it's not reasonable in that person to do an SI joint fusion and an L1 to S1 fusion. Like that's, the likelihood you're going to make that patient much better is pretty low. So that's, what's to do in that patient. That's kind of the methodical stepwise workup of X-rays, flexion extension films, CAT scan, MRI, injections. And even with the injections, being kind of systematic, like where is your stenosis the worst? And if it looks like you've got, some nerve root compromise on the left at L4-5, well, let's do a targeted L4-5, foraminal injection and see how much of your pain gets better. Well, not that much. Well, let's do the next level down. Don't do them all at once. It's not that helpful if you do them all at once, right? So sometimes I see people in clinic and I see a fluoroscopy or an intraoperative X-ray, and I see needles at like 4 different levels in the spine. They're like, yeah, I felt great. Well, I'm like, well, that's great, but it doesn't really help me because I don't really know which one of those levels was driving your pain. So doing an SI joint injection, doing systematic serial injections in your lumbar spine to hopefully find one or two that is driving maybe 50, 60, 70% of your pain, and trying to focus treatment on that. And that can be frustrating. And I'll tell you, we don't always find that, right? We have to accept that sometimes we don't find the magic bullet. We don't find the easy way out where this is 90% of your pain. We do a relatively small operation and this is it. It's in those settings where we start to consider alternative therapies, right? Like surgery it's not reasonable to take a shotgun approach to the spine and just try to blanket everything with a big fusion construct. But now we're looking at things like spinal cord stimulators and alternative therapies that are maybe a little bit outside the box to see if we can't get some relief that is meaningful to you, even if it's, again, not turning back the hands of time to give you the spine of a 20-year-old again. And that's challenging. It's frustrating. The process is difficult, but oftentimes we can get to a better place if we're really thoughtful and systematic about it. The SI just refers to sacroiliac. So it's the joint between the sacrum, which is the bottom of your lumbar. You can almost think of it as the bottom of your lumbar spine. It's the bottom of your spinal column, just above what you would consider the coccyx, or what you would consider the tailbone. And the joints between that and the wings of your pelvis is the ilium is your pelvis. And so that joint is called the sacroiliac joint. You have one on either side. It's actually, I think, the largest by surface area, the largest joints in the body. And it is not an uncommon source of arthritis, of back and hip area pain, sometimes overlooked and important to be part of that regimented workup in conjunction with our rehab doctors, pain medicine and pain management doctors, neurologists. Important to keep that joint in mind when we're systematically working through these issues.
Okay. Well, thank you so much there. Very helpful information. I know we only have a few minutes left. So Dr. Siva, I'll give you a quick question. And we might be able to fit in one more and we'll then close out for the evening. But Dr. Siva, for you, how long is it expected that spinal fusions of the L3, L4, L5, and S1 to last?
Oh, that's an interesting question. There's a lot of variability in that. Part of it has to do with how deteriorated either the levels that were fused or the levels around the levels that were fused were to begin with at the time of the surgery. The reason why it's hard to answer essentially is that, I think Dr. Gopez mentioned this earlier. Both the upside and the downside of a fusion operation is that on the upside is that you're stabilizing the spine in one area to allow you to do whatever sort of removal of bone and ligament is necessary to free up the nerves that are causing your pain. But the flip side of that is that, our body was designed in such a way that you're supposed to have motion at each level of the spine. And if you go in and put screws and rods in and achieve a bony fusion at 1, 2, 3, or even 4 levels, like what was described in that question, the other levels of the spine have to take on that extra stress because they're the only parts that can continue to move. And so whatever sort of aging process was already underway in those other levels that are still free to move often gets accelerated. And so we often see that if you have, for example, just a 1-level lumbar fusion at L4, 5, 3, 5, 7 years down the line, you may see that the level above or the level below has deteriorated faster than it would have otherwise. And now that level might need surgery. And the more levels that are fused, like in this example, L3 to S1, for example, the chance of needing an additional surgery within 5 years is, I would say, higher than 50%, definitely within 10 years. Because there's only a few segments of your lumbar spine that are left that have to sort of overcompensate and maintain whatever mobility is possible. And so, sometimes you're stuck and you need a fusion. The more levels that are fused, the higher the chance that adjacent levels will deteriorate faster. And so I think, probably the most important principle when considering surgery is really getting a good handle on, do I really need a fusion? Asking your doctor, whether it's a spine surgeon or a non-surgical healthcare provider, whoever it is, to really explain directly the thought process behind why a fusion is being incorporated into the plan for surgery. And then if it makes sense and you're convinced that a fusion is really necessary, to then ask, okay, do all these levels need to be fused? Or what if we only fused this one level? What would that mean in terms of my post-op recovery, short-term and long-term? And really sort of asking those direct questions and making sure that the answers that you're hearing are convincing and make sense. because I think as Dr. Holstrom mentioned earlier, there's no free lunch. There's going to be some downstream effects of a fusion, and the more levels that are fused, the more downstream effects.
Okay, well, thank you so much. And I think that was our last question for the evening, as we are just about out of time. And I want to thank our audience members again for such terrific and engaging questions. I know I learned a lot tonight, so thank you. But as we close out this evening, I do want to give one final opportunity for any final comments you would like to share with our audience members. So Dr. Gopez, I'll turn it to you if you would like to start our closing remarks for the evening.
Absolutely. So we heard a lot of great information out there from the different panelists. The bottom line is surgery does not fix everything. Surgery is not the correct answer for everyone. And probably the two big take homes I want to make are, number one, surgery for axial symptoms, so purely back or purely neck pain is oftentimes unsuccessful. Surgery, on the other hand, to fix radicular symptoms, and by that I'm referring to the extremity symptoms, whether they're in the arm or in the legs, has much more predictable results. So that's take home number one. The next point I want to really want to make is that I think it's important, especially if you're having surgery, that you ask questions during your face-to-face conference with your surgeon. I'm sure all the panelists here have seen patients for second opinions, and it amazes me that patients are how very little questions they asked of the surgeon that offered them the first surgery. So I think it's important to ask very good questions. One is like, you want to know about the experience level of your surgeon. How many of these have you done? You want to know what the risks are. Are there alternatives? What is the success rate? Okay, it's amazing. I find it amazing that, just the other day, I saw a patient that had purely axial back pain. The patient was offered a fusion. And I asked the patient, what kind of success rate did they quote you? And I was surprised to find that they had not even asked. Other questions you might want to ask is, how long will I be in the hospital? What type of anesthesia? Will I need to go to rehab? So my second point is that make sure you ask a lot of questions.
Great. Well, thank you. And I think that's an important takeaway for our audience members to remember from this evening, ask questions. So thanks for that reminder. Okay, let's turn to Dr. Fico. Any last comments from you this evening?
Yeah, well, first of all, I just want to say thank you all for listening. I want to thank you guys for the invitation. I want to thank the other panelists for talking. I learned a lot listening to them, so that was great to hear. I think that what I would say to all of our listeners tonight is that you should no one wants to live with pain, and I hope after hearing what we had to say, I hope that you realize that there are a lot of options out there. What I would say to you is that if your pain is lasting, on a simple level longer than 6 weeks, if it's limiting your ability to participate, if there were any of those red flags I talked about, you should see a doctor. I think that pain, if you treat it early and with a multimodal approach, like we practice here at Jefferson, is going to likely result in better outcomes. I think in thinking about those outcomes, therapy is extremely important to almost all aspects, whether it's pre-surgical or post-surgical pain. I think it can improve your pain levels, and probably even more importantly is improve your functional status, which in the long run, I think is a very important thing to be mindful of. And then, if surgery has not resulted in complete resolution of pain, and there were no other surgical needs going forward, I think it's important to partner with your surgeon, but also with pain medicine or rehabilitation medicine to look at what other technologies and options might be out there, and that might include something like neuromodulation.
Okay. Well, thank you so much. Again, some great takeaways to think through tonight. Appreciate you sharing your comments and appreciate your time this evening. All right, let's turn to Dr. Holscher. Any last comments from you?
Yeah, sure. And largely, I think we're all going to be echoing each other here to some degree, because the critical points are pretty basic and pretty common. One is to be an active participant in your care. Like a lot of people have said here, ask questions, and that's certainly part of it. Managing pain as it relates to your spine is challenging. Like we talked about, like most patients are some shade of gray. Like we like it when patients are kind of one or the other, but most of them are some shade of gray. And understanding, physicians' concerns, physicians' expectations for you, even in a best possible scenario, is really critical to a good outcome and patient satisfaction. Understanding that surgery is one tool in the toolbox, but it's not the only one. And a lot of that responsibility, frankly, falls on the physician. Like it's my job too to understand that, if my only tool is a hammer, so that old saying, if your only tool is a hammer, everything's a nail, right? And so if I think about your pain only in that kind of myopic view of, well, I see some stenosis at L4 or 5 and let's fix it, then we're kind of ignoring other potential drivers of your pain. And from the patient's perspective, it's important to understand that outcomes are not always predictable. Things are not black or white, and we may still have to be dealing with some lingering issues after surgery, even in the aftermath of a successful surgery. And to that end, the importance of a multimodal pain approach, like we just talked about, and engaging other providers, other specialties, and putting our minds together as one rather than trying everyone kind of treating a patient in their own narrow little worldview, usually leads to a better outcome.
Okay, well, thank you so much, Dr. Holscher. And finally, last but not least, Dr. Siva, any closing remarks from you?
No, I just want to say thank you as well for everyone tuning in and all the co-participants. I think just whenever you're talking to a physician or a healthcare provider about your spine or anything else for that matter, and particularly when you're considering surgery, I think it's important. I encourage everyone to really be clear about what your goals are, what you want to get back to doing, whether it's pain relief or being able to walk more, mobility, returning to work, whatever the case may be, to really make sure that the person you're talking to understands exactly what your goals are when you are on the other side of this whole process. And then making sure that in your gut that you feel like this whole process and the ordeal that's going to be involved with a surgery or injections or studies, that you feel like you're going to be able to move towards that goal. And if you're unclear about that, to really push the provider to really maybe adjust the plan accordingly, because it's really about the provider and the patient being on the same page about where you want to be when all is said and done. Sometimes that involves surgery, sometimes it doesn't. But that sort of communication, I feel like, doesn't always happen. It's partly incumbent upon the provider, but I think patients can also be a part of that by really advocating for themselves and saying that this is really what I want to be able to do. And how do you think we can get there through the various options that exist?
Okay, well, thank you so much. Keeping those goals in mind, asking questions, advocating, definitely themes throughout the evening, and we appreciate it. All right, well, thank you again, Dr. Spico, Dr. Gopez, Dr. Holscher, and Dr. Siva for your time this evening. As we close out this evening, we will be posting a website link that Jefferson is continuously updating with the latest information about the pandemic. We will also be posting a post-event survey so you can let us know your thoughts. Was this helpful? Is there another time that might work better for you? Any other specialties you would like to hear from? Your feedback will help us bring more virtual events like this to you, the patients. And we do have 2 upcoming wellness webinar series events about robotic surgery. So we will post a slide with those dates, time, and registration URLs. We will also post information on how to make an appointment with the physicians that you saw on tonight's panel. And of course, a recording of this event will be sent to you so you can rewatch it. If there is anything anyone here at Jefferson can do for you in this time of need, please feel free to reach out to us. Thank you again for joining us, and please be sure to stay safe and healthy. Thank you.